Okay, well, thank you. I think the use of non-invasive ventilation paralleled the use of the diesel car in the last 5 years. No? It crossed compared to the gasoline car in the last couple of months. So it's a pleasure to continue with this and with a fascinating topic, which is the neurally adjusted ventilatory assist. So trying to go closer to the brain signal. This system, which has been developed, a study mainly in Toronto, if I'm not wrong, will be presented by Kristen Sinderby from Toronto, Canada.
Yeah. Good. So I will take on to Marcus' scenario. So in this case, I guess the director will be Stanley Kubrick, and the movie is the 2001: A Space Odyssey. And we will see how we can, what our work is doing is to try to actually make the ventilator to become a mind reader of the patient. As very nicely pointed out by Martin Tobin in the New England Journal, was that patient-ventilator synchrony is very important. And on this slide we see the green line showing when the ventilator starts, and on the red line we can see where the ventilator should have started, because this is where the actual neural effort began. Similarly, we can see when the ventilator from the other green line stopped and when the neural effort ceased. We know from physiology that the dashed line is representation of where the actual inspiratory flow would stop. If we now look upon synchrony, we could see that the overlapping area between the open red line and the green line here is very small. If we now look upon where we would anticipate inspiratory flow from the patient and when the ventilator is actually delivering flow, the overlap is extremely small. This, as pointed out by Parthasarathi, results in increased expiratory muscle activation, and the patient is fighting the ventilator. Now, we talked today a lot about support profiles and how to deliver the assist. And my first question is to say, is there any use to try to deliver the assist if the window of overlap between the neural activation and the delivery of the ventilator is as short as, say, 50 milliseconds? So, the first conclusion from this work is that proportionality of assist is only possible where there is patient-ventilator synchrony. Now, as Marco already showed this slide and went through it very nicely, I'm just going to stop to the point that our work is to try to bring the control of the ventilator closer to the brain. And as far as we have got to the diaphragm excitation. Now, why would we like to have the diaphragm excitation to control the ventilator and not the flow or volume? I think this slide can illustrate that quite nicely. Here we see a healthy subject breathing with a tidal volume of 0.5 liters. The diaphragm activation is about, well, it's below 10% of its maximum. These two slides shows one severe COPD patient and one post-polio patient, both with chronic hypercapnia. And they both are breathing with a tidal volume of 0.5 liters in this case. But if you see here, the diaphragm activation is increased by more than 5-fold in order to maintain this ventilation. And this is what the disease makes to the patient. Conversely, if you couldn't hold this activation as high, you would have to lower your tidal volume. So when the failure progresses, at some point you can't keep up your tidal volume and the activation has to stay up still. This is why neural control might be of an advantage to pneumatic control. Now, how do we do neural control ventilation? Well, NAVA, neurally adjusted ventilatory assist, works by putting a nasogastric tube at the level of the diaphragm in the esophagus. We measure the signals from the diaphragm with an electrode array. We bring the signals to a computer, processing the signals, and let the processed signal control a servo ventilator in order to bring the effort of the patient in terms of neural activation back to the patient as a pressure. Now, one big issue is, of course, the thing of putting catheters into patients. And is this, if for Laurent's sake, is that non-invasive ventilation or not? I don't know, but we've managed to develop a new style of catheters, they can be made extremely small, like a size 3 French would not be a problem to host the electrodes. This slide shows a catheter of size 8 French. See the plug that connects to the EMG amplifiers. You see here is an electrode array, but that the electrodes are so small you barely don't see them. You see here in an enlargement the electrode, and this is a microscope picture of the electrode. The distance between these two lines is 1 millimeter. And this electrode is embedded in the wall of the catheter with a conductive plastic material. So this is to improve the interface to the patient's mucosa, so you don't irritate the mucosa. This is an antibacterial material, so it will not give you increased risk of infections. And the electrode is very small with no protruding edges. Now, how does neurally adjusted ventilatory support function? In principle, it is a proportional assist where the assist is the diaphragm activation times the gain factor transmitted into a pressure. So if we look at the bottom here, we see an intra-breath effect. You see a diaphragm electric activation for the inspiration, and you see the pressure delivered by the ventilator. It has a direct intra-breath response. It also has an inter-breath response. So if one effort is small and the next one is big, the assist will be small in the first one and the assist will be big in the next one. Furthermore, which is of probably great interest in infants, is that it also can respond to tonic activation of the diaphragm. So even if the diaphragm activity persists throughout expiration, tonic activity will keep the assist up like a controlled PEEP level, but controlled by the patient. Now, what are the requirements? And the time does not allow me to answer all the questions, but you need neuromuscular transmission, of course, you need a respiratory drive, and you need to position the electrodes. Possible problems: electrical noise, crosstalk from other muscles, and non-respiratory activation of the diaphragm. To illustrate how much signal you actually need or how much signal you can get from a patient, I took this slide from a late-stage Duchenne muscular dystrophy patient, 25 years old. This is the PDI tracing, put it on a scale of 5 centimeters because this is the anticipated normal PDI swing. And this is the tidal volume tracing. These are quiet breaths, and this is a TLC maneuver. This is the diaphragm activation that this sick patient has to generate. Even though his diaphragm is almost gone, the few motor units that are left can still produce sufficient activation to make a clearly detectable signal. Now, to Laurent's topic, do we have a problem with leaks? Do we have a problem with a weak flow signal? Do we have a problem with intrinsic PEEP? Well, this movie shows a person breathing on the NAVA system as it's set up today. This is a early prototype model. It was made a few years ago.
Doesn't matter.
And you see the nasogastric tube. This contains the wires for the electrical activity. And the girl is breathing. You can see her chest moving.
Take
you can see
deep breath in,
lung
because you
model.
can.
That is
And breathe out.
Can you turn off the sound, please?
And in again.
And you can see how the chest wall is synchronized to the lung model. A bigger leak than this, I don't think, can exist in the world. Now, what is the response of the system? And we talk about physiological response. We can, the green lines here indicates the onset when this is a bench study, when the neural trigger signal, when the signal is triggered, the ventilator, and to the time that the pressure starts to get delivered. And we are in a very short time of delivery here. So practically, at the time when the pressure starts to increase at the mouth is approximately at the time that the diaphragm starts to generate flow at the mouth too. So synchrony is very good. To cycle off the assist, we cycle off as a percentage of the peak activation, since this is where we usually stop breathing. And you can see here that the ventilator response is always also immediate. In terms of the response to variation in diaphragm activation, you can see that the assist delivered is different for each breath in proportion to the activation of the diaphragm, and point out that this is at the neural breathing frequency of 71 breaths per minute with a TI ranging between, well, around 200 milliseconds. There is a discrepancy between the ventilator pressure and tracheal pressure as anticipated due to the tube resistance. So there is a delay of the pressure that is delivered to the alveoli. However, the tube resistance can be overcome by this system because if there is an increased load, you can increase your activation and you get more assist. So therefore, we have a high frequency response and we have a kind of ET tube compensation with this mode. Now this slide shows a healthy subject breathing on NAVA before and after or during hyperinflation. Tidal volumes and flow rates are principally not altered. As anticipated, the hyperinflation gives an increase of the diaphragm activation due to muscle weakness. There is an increase in the airway pressure following the increase in diaphragm activation. And we can see that the work of breathing, as judged by esophageal pressures, gastric and PDI pressures, transdiaphragmatic pressures, is maintained in this patient. So NAVA just assists in response to changes in muscle function. Now, what is the influence of altered inspiratory loads? This slide shows also a healthy subject breathing on NAVA, 3 different conditions. NAVA only with normal condition. This is with increased elastance, and this is with increased resistance. Again, not very big changes in flow and volume were observed. We found that the diaphragm activation, of course, increased due to the load, and that the assist was increased in proportion to the increase in diaphragm activation. So we can conclude that NAVA just assists in response to changes in pulmonary, rib cage, and abdominal loads. Now, here comes the Kubrick part of the presentation. Here we have a healthy subject breathing into TLC maneuvers several times with increasing NAVA assist. You can see the assist level increasing as we increase the NAVA gain. We go from 0 to high gain. So the pressure goes up. You can see the transdiaphragmatic pressure going down, and at some point it's eliminated. You can see esophageal pressure swing becomes positive. This means that the patient is still breathing, but there is no work of breathing. This happens while the diaphragm activation only drops to 40–50% of the maximum. So we have significant amount of diaphragm activation, but we have no work of breathing. And there is little change in the inspiratory capacity, suggesting that even if you have force as Superman to breathe in, you don't increase your tidal volume or your transpulmonary pressure very much. So first of all, we find that we can perform 100% unloading with spontaneous breathing, with a reflex control of inspiratory volumes. That means there is no runaway. And note especially, total diaphragm unloading doesn't mean inactivation of the respiratory muscles. To further illustrate this, we have a person breathing with high gain of NAVA, performing 0 work of breathing, and this person is doing different volume maneuvers. You can see here 2 tidal breaths and then an inspiratory capacity, 2 small increases in diaphragm activation during the tidal breaths, and a big one during the activation, during the big inspiration. Airway pressure, small pressures during tidal breath, big pressure during TLC maneuver. Esophageal pressure swings, positive, positive, and more positive. transdiaphragmatic pressure swings more or less zero. The timing, the synchrony of the breathing here is perfect still though. And for quiet breathing, these patients do not change tidal volume, respiratory rate, or minute ventilation. So it means that you can, in a 100% unloaded patient, maintain spontaneous breathing, but can also control timing and delivery of assist regardless of the tidal volumes. So in conclusion of this presentation, NAVA offers the possibility for guaranteed diaphragm activity during mechanical activation, since we must activate the diaphragm to get assist. Automatic response to changes in respiratory load and muscle function, maintain patient-ventilator interaction independent of patient interface and at extreme unloading and breathing frequencies, and the reflex termination of assist, which might have a potential impact on lung injury. Thank you very much.